Welcome to the final workshop session. So we're going to be joined by the moderators from the 6 workshop sessions, and we've asked everyone to summarize the key findings in this session and highlight the policy opportunities to advance progress in the use of integrated diagnostics in cancer care. So just to give you a sense of how this is going to go, the moderators will have 5 minutes to review key issues speakers identified in this session, emphasizing policy opportunities to advance progress. Following the summaries, we'll have a roundtable discussion, and you can see the assembly of individuals on the, it's not exactly a round table, but it's a table. We'll welcome workshop speakers and attendees to contribute to discussions. And as usual, we'll ask that you, when you step to the microphone, announce your name and institutional affiliation, or individuals who are participating online should send in their questions using the chat box on the website. So now it's time to hear from our moderators.
Thank you, Kojo. Can I have my slide, please? Or I can move? What's this? Okay. So the conclusions that I am presenting, I want to say thank you to Kojo, of course, Travis, and Mitch Knoll, who just left, gave us. We did this together, and then at the end, the tool was criticizing it. So this is a joint presentation. And number one, I hope you all agree that diagnostics is moving towards data science. And I think there was a consensus that there is a need for data integration. Number two, we really need clarity. What is integrated diagnostics? Follow to Joe's comment. Integrated diagnostics is not clinical decision support system. Clinical decision support system has the elements of reminding a patient for screening, of looking at the guideline, NCCN guidelines, at doing all the sensors that patient may or may not have. Integrated diagnostics is integration of diagnostic tests. Dashboards are not integrated diagnostics. Dashboards are display of the findings. Only when we integrate are we going to have the power of prognostic and predictive biomarkers and suggestions for therapy. I think, we believe we need to remain flexible in the scope of the integrated diagnostics. And sometimes it's just integrating all the tests within one specialty, or integrating 2 or 3 tests depending on the needs. Ultimately, we would like an automated integration of all findings. But I think even the most optimistic people know it will take us at least 5 years. And then we cannot forget that fundamental patient-driven goals for integrated diagnostics are at the center of what we are doing. I keep saying that integrated diagnostics are going to decrease medical errors, because you're going to have a better idea when to treat, how to treat, and that is the key. Medical errors are a problem. The big issue with integrated diagnostics is return on investment. There are, like at Penn, it was integrated diagnostic funded by the department. In some, it is funded partially by institution. But it is very difficult to demonstrate profit and loss in short term. And in many institutions, and especially moving forward, they all want to know P&L. If I give you a few $1 million, you need much more than a few, what's return on the investment? But in the long term, we will have return on investment. We just have to really change the outcome from billing to other measures of outcome. It is the same with PACS. I know some people say we can get, but PACS is really not immediate P&L. When we ask for PACS and upgrades, we don't even do P&L. And then incentives. We have to, this will not be Kojo kept saying incentives. Opportunities are tremendous, but we have to solve a few problems. Number one, and I'm looking at our industry, gentlemen, interoperability of the systems. I believe your system is the only one that has radiology and pathology on the same platform. There has to be interoperability between you and all the other systems as well. Standards. Travis was trying, there are standards off and on. Synoptic reporting and certainty lexicon. And that has to include radiology, pathology, surgery, clinical notes, and has to address diagnosis, staging, and follow-up. A very painful subject of annotation and segmentation. We have to move away from the manual. We just have to, because we need large data sets. There's no way that it will take us years and years to annotate 1 million scans. We need to move now in stepwise fashion, maybe augmentation first, but the ultimate goal has to be to automate. We have to trust that it won't be perfect, but we do need large data sets, and we need it. Data equity. We heard about deserts of data, and we do know that depending where you go, you're going to have 15 tests for the same diagnosis that someplace else you may have 2. So is the data, the equity of data? Culture. I know we all like Drucker's, the strategy, the culture eats strategy by lunch, but I think in integrated diagnostics by breakfast, unless we are really careful. Partnership, but sincere partnership that has to have incentives. And data sharing. I think with NCI, what's happening, and ARPA age, maybe we'll get more used to data sharing, but we are not there. We don't even share data between the departments in the same institution. We all have our own data sets. Reimburse for diagnosis and not for procedures. We really like that concept. I'm not so sure it will come in the United States soon, but it's really a lovely, it's a very nice concept. Precision diagnosis scaled at population level for the impact on individual level. That's really the key. And integrated diagnostics is a closed loop. We continuously learn, computer continuously learn with the feedback. So with the larger data sets, the more powerful we are going to be. And we need the governance in each institution, of course. It's very successful in some institutions, and it can be done. And I think most of all, we always have to remember integrated diagnostics is patient-centered approach. Patients, I know there may be a controversy, but in cancer, I come from a cancer hospitals. They like to see their data, and they like to see them immediately. And if the study isn't read by afternoon, a patient has study in the morning, and there is no result there on the portal by the evening, they actually call us. So they like to see the data. Sometimes it's frightening, but there are many patients that really want to see the data. And they're going to love seeing integrated diagnostics data plus the biomarkers. And then when they come for the visit, there is truly shared decision-making on the treatment. So that's from our session, and thank you very much.